And so we'll start with me doing hepatobiliary and pancreas, and then Ed or Isaac will be doing the upper and lower GI stuff. So we'll get started with SBA. Is the poll? Yeah, the VBox is all good.
Yeah, we've got a link in the Teams chat that everyone can use.
Yeah, so it's in the Teams chat to get to the VBox poll, and we'll start with an SBA.
Do you want me to close it when I fancy, or do you want to tell me?
Close it when you fancy, I think. Close it when you think we've gotten all the responses we're going to get. So UCL aren't particularly PC with their demographics. If they're mentioning kind of anyone's nationality, anyone's ethnicity, or their housing status, it's usually pretty relevant and important. So no fixed abode is another way of saying someone's homeless. And in SBA land, that kind of usually means one of a few things. Alcohol or drugs, bloodborne viruses, or kind of certain infections like TB or Klebsiella and stuff like that. So here we have a fairly generic acute liver presentation, although with confusion and reduced alertness. But with the demographics, the transaminase is just kind of in the hundreds, and a 2-to-1 AST to ALT ratio, plus fatty liver on the ultrasound. What we're looking at is alcoholic hepatitis. So management of this would usually involve IV fluids, and prednisolone and steroids are sometimes also given as well. So we've covered the acute presentation of alcoholic hepatitis, but we'll go through alcoholic liver disease. So in terms of its chronic presentation, you have 3 distinct stages, which you go from fatty liver to hepatitis and necrosis, and then onto finally cirrhosis. In general, many chronic liver diseases can present fairly similarly, but there are a couple of ways of differentiating that it is alcohol that's causing the liver disease. So a way a doctor told me to think about this is to think about a generic rugby lad drinking a beer. So the Dupuytren's contracture is their hand holding the glass, and the parotid enlargement is from all of the thick-necked rugby boys drinking. That's just a way that I was told to remember it. Take that as you will. And another thing you can see in them is certain nutritional deficiencies, so your thiamine, or just general malnutrition. Finally, it's important to screen people for HCC, and you do have an ultrasound every kind of 6 to 12 months if they have established cirrhosis. So management is basically focused around stopping any progression and stopping any complications, and the best thing is for them to stop drinking. So on to the next question now. So we've got a longer presentation here in a middle-aged woman with kind of something grumbling along the background for a few months, and this has come to a head with her getting jaundice. So the inclusion of other autoimmune associated conditions like celiac, thyroid, or type 1 diabetes is a really important clue they want you to think about autoimmune conditions and pathology. So what we're looking at here is autoimmune hepatitis. So amenorrhea is a feature of autoimmune hepatitis, and it's a good one to distinguish it from fairly similarly presenting pathologies. And then anti-smooth muscle antibodies, the most common type you find in the most common type of autoimmune hepatitis, which is type 1. This isn't PBC or primary biliary cirrhosis, mainly due to the amenorrhea, the lack of itching, and PBC would have a more cholestatic picture on the LFTs. So we've covered most of the presentation of autoimmune hepatitis in the SBA. It can present quite vaguely, and you're looking for those other autoimmune pathologies in the stem, which can be very helpful in distinguishing it. In terms of investigations, also you would want to probably confirm with a liver biopsy and something like this. So as we said in the question, the most common type is type 1, and 80% of these people have anti-smooth muscle antibodies, and the treatment is varying levels of immunosuppression, basically based on how severe the disease is. So on to our next question. So this is a question that comes up time and time again. So hepatitis E has a disproportionate mortality in pregnant women. Any pregnant woman with an acute hepatitis picture that gets worse unexpectedly has hepatitis E for your 4th year UCL exams. They ask this time and time again. So the history provided, I tried to kind of be a bit of a red herring for hepatitis A, which is more common in general, but as soon as you see pregnancy in the stem, you're thinking hepatitis E. So here we've got our acute viral hepatitises. Both can present quite similarly and quite non-specifically. Both will be diagnosed with an IgM antibody test, and both are managed fairly conservatively. There's not much you'd do in terms of drugs or anything like that. And both can have their symptoms take a few weeks to come on because of the incubation period. Then we have our hepatitis viruses that generally cause a more chronic picture, although do note that 30% of people in both Hep B and Hep C can get signs in the acute phase. So they're opposites in terms of a few things. Hepatitis B will rarely cause chronic infection in adults, so 95% of people will clear it. But in terms of mother to child, it passes 90% of the time vertically to the child. Whereas with hepatitis C, it's got a low vertical transmission, but 70% of adults infected with it will get chronic infection. Then we have no vaccine for hepatitis C, but drugs can cure it in the vast majority of people. And there is a vaccine for hepatitis B, but drugs can only slow its progress rather than curing it. So I thought I'd talk about what kind of happens immunologically in Hep B infection so we can get to better understanding the serology and all of that stuff. So the first thing that happens is you'll get infected with Hep B virus in your bloodstream. And for the sake of the this explanation, what it brings with it is its surface and core antigens. Now, second thing is your body responds. So the body responds by producing IgM, which we'll see in the acute response to any infection, really. So the core antigen is easier for the body to kind of recognize and figure out. So initially, the body pumps out IgM antibodies to this hepatitis B core antigen. Now, as we said, 90% of people clear the infection. In these people, the body figures out the most important surface antigen and starts producing IgG, the more kind of long-term antibody response to the hepatitis B surface antigen. Now, this anti-hepatitis B surface antibodies, they're the real key to clearing the infection. And if you have these, you've cleared it or you're immune. So after a while, about 6 months, the initial IgM response to that core antigen gets cleared away, it's made redundant, and the body then also makes IgM against the core antigen. Now, in the minority who get chronically infected, the body fails to work out the all-important surface antigen and make antibodies to it. The body still produces antibodies against the core antigen, but these don't really do much as it's not important, and the virus kind of wins and sticks around, really. So this brings us to the serology element. So we'll kind of go through the scenarios one by one, explaining what you get. So someone who's susceptible will not have seen the virus before, therefore has no antibodies or viral parts, basically. Someone who has been infected in the past will have that long-term IgG against both the surface and the core antigens, and they won't have any viral parts in their bloodstream. As we've said, it's the antibodies against the surface antigen that are all important, while antibodies against core antigen don't do much. Therefore, they don't include the core antigen in the vaccine. So someone who is vaccinated will only have antibodies against the surface, but not the core antigen. Finally, we have the people who are infected. In these people, they do not have the all-important antibody to the surface antigen. They have the virus in their blood, so you can see the Hep B surface antigen. Then you can tell whether it's an acute versus chronic infection based on whether they have IgM or IgG antibodies to the core antigen. Finally, there's this thing called the hepatitis E antigen. This is basically a marker of showing how quickly the virus is replicating and how much it's replicating. It's just a high level, just shows high virus activity and vice versa. So on to the next question.
Just while we've got a break from you talking, Ollie, someone said this is the first time they've ever understood Hep B serology.
That's why I had a whole page trying to talk through it. So I threw in a fairly difficult question as I wanted a teaching point from it. So what I'm asking is the best blood test for telling someone that just has cirrhosis rather than any other stage of chronic liver disease. So the key thing about cirrhosis is that it's a structural change in the liver. There is not necessarily a change in function or transaminases than from any other stage in chronic liver disease. What the structural change means is that there's a backup of blood into the portal vein, and this causes portal hypertension. This all backs up to the spleen, which causes platelet sequestration in the spleen, and this is what leads to the thrombocytopenia. So the key in cirrhosis is it's a structural change rather than any functional change. And this causes portal hypertension. This can be useful when you're looking at someone who's come in with an acute upper GI bleed, as thrombocytopenia can give an indication that there's portal hypertension going on, and therefore it's variceal rather than any other type of upper GI bleeding. So it's a niche point, a difficult question, but I think it shows the key thing about cirrhosis. I'm glad everyone also went for albumin rather than anything else, because this is showing the synthetic function of the liver, which is important as well. So cirrhosis is the common endpoint of many chronic liver diseases, where the liver kind of becomes this like new nodular structure. So in the bottom left, we have some general signs of chronic liver disease, which you might see in an OSCE. This kind of chronic liver disease patient is by far the most likely case for any abdo exam or any kind of clinical gastro or anything like that. So the body can cope even for cirrhotic liver quite well, but it can be tipped into what we call decompensation, where you get stuff like ascites, encephalopathy, and jaundice. And it can be tipped into this by stuff like infection, upper GI bleeding, alcohol binges, or by constipation as well is a very common one. And this is important because the body is unable to excrete nitrogenous waste through the feces, and this can tip people into decompensation. So again, in anyone that's cirrhotic, it's important to screen people for HCC, but the most important thing is just to treat what's causing the cirrhosis, and for many people, a transplant is the only option available. So here are the three most important complications you see in these patients. So you've got ascites, where you get fluid in the peritoneal cavity. So this can be caused by a few things, but cirrhosis is the most common one. Basically, think of the causes of it being like a pleural effusion. So you can have like hypoalbuminemia causing it from stuff like nephrotic syndrome, or you can have infection and other things like that. And the management of ascites is sodium restriction, as this is involving like the hydrostatic things, everything like that, and spironolactone, as high aldosterone plays a big role in ascites development. If it's recurrent, you can consider something called a TIPS, where the hepatic and portal vein are connected, basically bypassing the liver. The consequence of this is it causes a big rise in like ammonia products in the blood, and so it can worsen or tip people into hepatic encephalopathy. Ascites can get infected, and this is called spontaneous bacterial peritonitis. The key to diagnosing this is the number of neutrophils in the ascitic fluid. You'd always do a paracentesis if you suspected it, as it can present quite subtly. Finally, we have hepatic encephalopathy, where high ammonia products cause problems in all aspects of the nervous system. So lactulose and basically pooing it out is the main treatment of that. You just want to cause the high frequency of loose stools, like 2 a day, they say, to try and get rid of all the ammonia products. So I thought this is a nice graphic showing the 4 kind of areas that get affected in hepatic encephalopathy, and just how they go down through the stages of it. But I wouldn't worry about learning the stages or anything like that. I just thought it was a nice illustration. So on to the next question. So I've been a little bit mean here, given that I've been banging on about screening for HCC with ultrasound. But here there's a high suspicion of HCC due to the fact you've got an abdominal mass and cachectic patient. So you go straight for the more invasive, better imaging of a CT or MRI. And also the question is the tricky art wording of most likely to reveal. It's kind of like the best investigation. Whereas if you're screening people just with cirrhosis, you want to do an ultrasound rather than subjecting them to more invasive imaging. So HCC is almost always develops in an already cirrhotic liver. The one exception to this is in hepatitis B infection, or chronic hepatitis B, as hepatitis B is like a carcinogen for HCC itself. As I said, you want to screen for it in the big four causes of cirrhosis. So in alcoholic liver disease, non-alcoholic fatty liver disease, then the hepatitis B and C. I wouldn't worry too much about its treatment. It's as with any kind of cancer in fourth year, really. So speaking of which, I want to do a quick note on non-alcoholic fatty liver disease. So it's incredibly common and it's very similar pathogenesis to alcoholic liver disease, with hepatic steatosis, so fatty liver being the first step. It's associated with diabetes, insulin resistance, and all of those the like. And though it can be precipitated by some extreme weight loss or by periods of starvation, actually, as well. So you can do this blood test called an enhanced liver fibrosis test, which basically uses blood markers to determine the risk of fibrosis. And then you maybe biopsy or anything like that based on that score. And weight loss and diet are by far the best way to stop its progression and improve symptoms. So on to the next question. So here we have a young, healthy chap that's going through a period of stress and nothing else is found on history or exam or investigation. So all of that points to Gilbert's, a mild bilirubin conjugation defect. So now we're on to the big presenting symptom of hepatology, jaundice. So you have our inherited conditions where something goes wrong in the bilirubin metabolism pathway. Gilbert's is probably the only one you actually need to know about for fourth year. In Gilbert's, you get a mild defect in UGT1, and which is the enzyme that conjugates bilirubin, leading to its presentation of a mild, isolated, unconjugated hyperbilirubinemia. And they get that in times of stress, at times like exams, fasting, periods of like acute viral illness, anything like that. So cryoglonasia is the same thing, but way more severe and presenting in kids and is very rare. And the other two are exceedingly rare as well. And you probably don't need to worry about them, but I just included them for completeness. So I thought I'd run through kind of what's going on in bilirubin metabolism and why it leads to the different signs you get with different types of jaundice. So if you look on the left, the top right, you can see the pathways. So heme is broken down to unconjugated bilirubin. This travels in the blood to the liver, where it gets conjugated by that UGT1, as we saw of Gilbert's. And this conjugation actually happens very quickly. So the conjugation is then conjugated bilirubin is then secreted into bile, which takes quite a long time. Actually, this is the longest step in the liver. So bile goes into the gut, where the gut bacteria make this thing called stercobilin, and this is what gives feces its brown colour. Now let's see how various pathologies influence this. So in prehepatic, there is a high unconjugated bilirubin, as there is way more heme than the body is used to getting produced. This is usually from stuff like hemolytic anemia. So the urine is normal colour, since unconjugated bilirubin is not water soluble, therefore can't go into the urine. And the stools are normal colour, as the liver and bile ducts are still working fine, and you're getting that stercobilin being made in the gut. So in hepatic, the main problem is in the secretion of conjugated bilirubin into the bile. This means that conjugated bilirubin builds up and then leaks into the blood and urine, and this turns the urine dark. There's still some bile that gets secreted into the gut, so there's still enough bile getting in there that you make the stercobilin to make the feces brown. Finally, you have an obstructive jaundice, where there's a complete blockage of the bile flow. So you get conjugated bilirubin leaking into the blood and urine, and none of it is getting to the gut. So therefore, you get no stercobilin, leading to the pale stools that you get in obstructive or post-hepatic jaundice. So thanks for sticking with that. I just thought it's helpful when trying to understand why you get what signs of each type of jaundice. So here are the top things you should be thinking about when someone comes in with jaundice, the most important. And here are some of the rarer ones. I'll touch on most of these at different points, but I'll just say about a couple of what things now. So hepatitis D is pretty rare, and it can only occur when someone already has a chronic hepatitis B infection. Wouldn't really worry about it. And cholangiocarcinoma is a cancer of the gallbladder, and that'll present fairly similar to pancreatic cancer, and it also has quite a poor prognosis. So in terms of investigating someone coming with jaundice, we want to look at the synthetic function of the liver and the LFTs. We're wanting to look for whether we think it's prehepatic or post-hepatic, or hepatic, obviously. And most important out of these is assessing for mechanical obstruction with ultrasound. So all of these people should coming in with jaundice should get ultrasound of the bile duct biliary tree. As if there is an obstruction, something like a stone, this is something you can easily rectify with intervention. On to our next question. So this kind of subtle neuropsychiatric presentation is actually quite common with Wilson's. Anytime you see neuropsychiatric and liver symptoms, you should be thinking of Wilson's. But what is going on with the copper and all of that stuff? So Wilson's is a defect in a gene called ATP7B. That's not really important, but what is that's the gene responsible for making ceruloplasmin. So ceruloplasmin is an excellent transporter of copper, and usually you'd have in the blood, you'd have 95% of the copper bound to ceruloplasmin, with 5% of it just being free copper. So in Wilson's, you have reduced ceruloplasmin because it's not getting made due to this genetic defect. So therefore, you don't have the 95% of copper in the blood that's usually bound to ceruloplasmin. Therefore, the overall serum copper goes down, but the free copper goes up. And this free copper can deposit in the organs, causing the different pathologies you see, and also in the urine, making the urine copper go up. So we're on to our inherited liver conditions now. So we've talked about most of this, but I just wanted to quickly focus on management. So the traditional management is penicillamine, but we are seeing newer therapies like triantine coming out, but these are still quite expensive. So technically, you go for something like a zinc or a triantine, but most people would still do penicillamine. But it's got a lot of side effects. They're trying to phase it out, but it's still the old school answer and the prompt one you probably have in a UCL exam. On to our next question. So this guy has the three most common symptoms of hemochromatosis, which are arthralgia, fatigue, and ED. So then he also has signs of pseudo-gout, which is associated with hemochromatosis. Then we have confirmation that he has the associated mutation, and then now we need to think about management. So the first line management is regular phlebotomy, as iron chelators can have quite nasty side effects, and lifestyle modifications isn't enough to kind of reduce the iron that could cause damage in people with hemochromatosis. So in hemochromatosis, you have a genetic mutation that causes you to absorb more iron than you need from the gut. This then can deposit in organs, which can and the damage that it causes can either be reversible or non-reversible. So on these people, you'd initially do iron studies, looking at the transferrin, but usually would confirm with genetic testing. On to our next question. So the key things here that they took the tablets all at once, and it's been 2 hours since the overdose. So there are no immediate indications for NAC, and the time for activated charcoal has passed. So you need to wait until the magic 4 hours post ingestion and test the blood paracetamol levels. On to the next question. So this is testing the King's criteria for transplant and acute liver failure. We'll see them all in full in the next slide. And I don't think it's something particularly get worried about, but acidosis 24 hours post overdose is enough to justify liver transplant. So it's a very important topic, gets tested all the time, paracetamol overdose. So the evidence for activated charcoal or gastric lavage is poor, but you'd still try it if they're presenting within an hour. Bottom left is the indications for immediate NAC from the BNF. I think the key one to note is if they've had like a big overdose, you'd start NAC as soon as possible if they've presented after 8 hours. And the bottom right is those King's criteria. As I said, just learn the acidosis one, as it's the only one that would be on its own enough. They're actually based on epidemiological studies from the 70s rather than like there was any kind of physiology or anything I can find. This is a Moodle explanation from a finals quiz showing what UCL think about it. So the final thing from paracetamol overdose and everything like that is that NAC is associated with an anaphylactoid reaction in some people, which is basically presents like anaphylaxis, but it's not IgE or mast cell mediated. So here are the other drug causes of liver injury, with the one in bold being the most important one I feel like you need to know for each of the 3 presentations. So this is like a nice flow chart. I won't fit kind of with the different presentations that someone could have with their LFTs. I won't focus on this now, but it's something to go through in your own time. But I do want to particularly focus on transaminases or your ALT or AST. So these are enzymes that are in hepatocytes. You pick them up on a blood test when hepatocytes burst and die. They then release these transaminases into the circulation. So you would see a much higher ALT or AST in acute liver injury because you have previously healthy cells that are working well, efficiently with lots of enzymes in them that then suddenly die by necrosis, releasing vast amounts of the enzymes into the blood. So you can get astronomical ALT or AST readings in situations where you have a completely healthy liver that's then hit by a huge, very sudden insult. This is times such as ischemia or drug overdose. So you can get numbers in the low thousands in acute viral hepatitis, as it's a slightly less sudden insult. And then numbers in the low hundreds in alcoholic hepatitis, again, since it's slightly less kind of sudden and severe. Alcohol does not usually cause transaminases in the thousands. So now onto why numbers are low or even normal in chronic liver disease or cirrhosis, when the liver can be much more damaged sometimes. So you have a smaller number of generally unhealthy cells that are producing less ALT and AST that are dying at a slower rate by apoptosis. This means that what the value you measure in the blood is probably a lot lower, given that unhealthy cells that are dying a lot more slowly with a lot less enzyme in the first place. So your ALP or gamma GT are produced in the bile ducts, explaining why they go up in cholestasis. But note is ALP can also be produced by the bone. And finally, you have the markers that show how well the liver is actually working. So this is albumin and clotting that show the synthetic function, and bilirubin, which is showing how well it is excreting the things it needs to. So on to the next question. So this is testing a bit of the Hep B serology from earlier, plus a niche little UCL exam fact. So this is the only pathology I'd be aware of from liver or hep or anything like that. And it's just knowing this buzzword of ground glass hepatocytes in hepatitis B or chronic hepatitis B infection. As I said, I don't think you need to know any more than the ground glass hepatocytes I just mentioned, but here's all of the liver biopsy buzzword phrases just so you have them as a reference. So cheers for sticking with me on the kind of dense workings on the liver. So the rest of this should be a bit quicker and less wordy. So here's a nice diagram showing the biliary tree before you're subjected to my Microsoft Paint skills. So basically wanted to run through the basic terms that you get in gallstone disease. I think it's never properly explained. It can be quite confusing. So cholelithiasis is just the name for there are gallstones in the gallbladder, not necessarily causing anything, but they're just there. If one of these stones gets temporarily stuck in the bile duct, and the bile duct will maybe spasm, trying to squeeze, just push it along, this will cause the pain of biliary colic. If the stone gets stuck for a prolonged period, the gallbladder can become infected or inflamed, leading to cholecystitis. Then we have Mirizzi syndrome. So this is quite rare, but it's where you get a really big stone in the gallbladder, which compresses the common bile duct, leading to obstructive jaundice when you've just got cholecystitis going on. So clinically, it's very hard to distinguish this from acute or ascending cholangitis. I don't think a question asked you to. Then you have Choledocholithiasis, which is where you get a stone that's stuck in the common bile duct, and this can cause symptoms or not. This is the name if you find any of them on the common bile duct on ultrasound. And then finally, ascending cholangitis, where you get an infection of the biliary tree, most commonly caused by an obstruction and usually a stone. Finally, you can get pancreatitis, where the stone, if it's caused by a stone, it's where it's traveled all the way down, it's blocking the pancreatic duct. And then here my Microsoft Paint skills failed me a bit, but in gallstone ileus, again quite rare, but you usually have a stone, a very big stone that causes a fistula between the gallbladder and the bowel, and then it can get stuck and cause a bile obstruction. But again, it's quite rare and I wouldn't get too worried about it. So on to our next question. So the key here is recognizing the patient is septic. So you're going to need to do all your parts of the sepsis 6. There'll be a ton of questions where you've got to recognize the patient's sepsis and either do investigations or the treatment in sepsis 6 before doing anything else. So lots of people get gallstones and gallstone disease. You need to do an LFTS on these people to check the liver isn't being damaged by obstruction or the stones or anything like that. And then you want to do an ultrasound to detect the stones and evaluate for bile duct dilatation. So you'd only do an MRCP If ultrasound has not directly visualized the stone, but you have evidence there's one there, like bile duct dilatation or the LFTS being deranged with no other reason for it. And the treatment is surgical and based on whether they have symptoms or whether they're on the common bile duct or not. So the way to tell between these two is usually whether they're jaundiced and how unwell the patient is. So your first investigations in cholangitis are more about ruling out sepsis. So your blood cultures and your ABG first. Then you'd be looking to use ultrasound to evaluate the biliary tree. You can only do an ERCP if you directly visualize the stone on some imaging, as it carries a risk of causing pancreatitis. So both of these conditions have quite stereotypical presentations. If you're a middle-aged itching woman with deranged LFTs or jaundice in PBC, and they will mention UC in the STEM if someone has PSC, given it's 80% of people will have UC. So PSC, or primary sclerosing cholangitis, is where you get inflammation in the biliary tree. This explains why they have an increased risk of cholangiocarcinoma, so cancer of the gallbladder, also the gall duct. Whereas in primary biliary cholangitis, you get inflammation in the intrahepatic bile ducts. So this is why they have an increased risk of HCC, so hepatocellular carcinoma. On to our next question. So the main point here is that a raised amylase is not specific to pancreatitis, so don't immediately pick pancreatitis or pancreatitis management, which the top one is, if the history fits much better with something else, which here you're thinking of bile obstruction, given the bilious vomiting, the lack of passing stool, the fact they haven't had any symptoms before, and the elective hysterectomy, so you're thinking adhesions are very likely. So now we'll quickly go on to the pancreas. So any pancreatitis is excruciatingly painful, as it's basically one of your organs effectively digesting itself. The key with acute pancreatitis is rapid, aggressive IV fluids and strong analgesia. Also, I think I get smashed, all of those things that you learn so well, and I don't really know why, as I think someone like Dr. Dilworth said, someone like that said it'll only be caused by alcohol or gallstones in your exams. But that's a way to remember the causes. And then you have chronic pancreatitis, which is usually either caused by repetitive acute pancreatitis or something like cystic fibrosis. And in chronic pancreatitis, you're replacing the natural functions of the pancreas with what you're trying to do with your management, and also give analgesia. Then you have pancreatic cysts and the like. So pancreatic pseudocysts can develop after an episode of acute pancreatitis. They can be fairly in the background, just having a mildly raised amylase, or they can cause mild abdo pain. So we generally leave these alone unless they're symptomatic for over 3 months. So I'd never actually heard of pancreatic cysts when I was in 4th year, but it's something Gavin Johnson seems to mention a lot. And I think the only thing to know about them is that mucinous is bad. They're usually high cancer probability, or malignancy transformation probability, and serous is more reassuring. So,
sorry, it'll only be 1 minute. Just because this links to what I was saying in vascular surgery, pseudocyst is a differential when you have an expansile upper abdominal mass. So when I was talking about AAA, which expands and contracts, this just pulses without the contraction expansion, or it can do.
Lovely, a bit of linking between topics. Then we've talked a little bit about pancreatic insufficiency in the context of chronic pancreatitis. So it's the same sort of things that are causing it, and you'll need to replace the natural functions of the pancreas. And we usually actually see the exocrine, so the stuff like the pancreatic enzymes involved in digestion, they usually go first with diabetes and stuff like that. Based on the endocrine function, that comes a bit later on. So in people with chronic pancreatitis, you'd usually see the first thing to go would be them getting the kind of the bloating, the fatty stools and everything like that. And then you test their blood sugar and monitor it to see if they then later develop diabetes. So I think it's a final question of mine. So a painless, palpable gallbladder, which is what's been described here, is a sign of pancreatic cancer. So the gallbladder is not palpable in the same way in gallstone disease, as the gallstones basically rattle around in there, causing inflammation and then fibrosis. So if you've had gallstones in there, it actually won't stretch to anywhere near the same degree as when you have a blockage from, say, from a tumor at the head of the pancreas, which then it can then expand very quickly, leading to this painless, palpable gallbladder. Then this picture is of a Trousseau's sign, which is the other weird eponymous sign you can get in pancreatic cancer. The main thing you're looking for with this disease is your jaundice, so your painless, obstructive jaundice and weight loss. So, but you would want to be evaluating anyone who's over 40 with jaundice for pancreatic cancer. It has an absolutely terrible prognosis, as it generally presents very late and is aggressive. And the best way to look at it is what's called a pancreatic protocol CT, which is the special way of doing SCT abdomen. Sorry. So that's the end of my section. So I guess we're at 6:30. So I guess it's up to you guys whether you want to go on with the GI side, or whether you'd rather save that for another day.
Yeah, so I've put a poll in now. So if we do it all now, it'll realistically be another hour, maybe hour and a half. If we do just upper GI, that might be like half an hour, 45 minutes. In which case we could fit lower GI in with surgery another day, or we can just stop now. We'll see what you guys want. Like, we're easy either way.
Mm-hmm. Don't want it to go on too long and kind of everyone get a bit tired.
We need more people to vote. We've got 21 votes and each option has got 7, so we're no better off. We've got 5 people who potentially could send in a vote in the VVOC session.
We've got some people who aren't able to vote on the VVOCs as well. It's not working for a couple of people.
Right, we have, I'm going to stop it there. The winner is just do upper GI now. So let me take a 2-minute break and we'll go through upper GI. So we're doing esophagus and stomach and duodenum. Yeah, cool. I'll take 2 minutes and then we'll start. Right, we'll get started in a sec. I've just looked at the VVOX chat. Someone said, my comment about the vignette that was guaranteed to come up, I was joking. I was talking about the scorpion one that someone put in. Yeah, as Ollie says, it's always alcohol and that. Common things are common. Right, we'll start on the first question. I haven't done this before, trying to man, oops, not that one, trying to man the lecture and the VVOX at the same time, so bear with me. Here we go. Okay, I'm going to stop it. It's quite a tough one, this one. It's not black and white, the presentation that I've given, but I'm trying to get at the point that this guy's had long-term reflux disease that's kind of refractory to treatment. So I was suggesting this guy's got Barrett's esophagus, which is metaplasia or change from the standard stratified squamous epithelium that you usually find to pseudo-stratified ciliar, non-ciliated columnar that it changed to, which we'll come back to. It's one of those bullshit pathology things, either know it or you don't, but now you all do. So we'll do another question. And then we'll go through this stuff again. Okay, I'm going to stop it there. This is we've got an interesting spread again, so I don't want to make you all think that the questions are going to be really hard. I've just picked this because it makes an interesting learning point. And we had this question, I found this on Moodle, it's been in a UCL quiz. It doesn't talk about dysphagia, which would make a suspicion of upper GI cancer kind of higher up the list. But the weight loss, a publican is a landlord, by the way, so weight loss in a guy who drinks loads, smokes loads, and has a history of achalasia, which is a risk factor for upper GI cancer, or for esophageal rather. It's kind of pointing towards cancer of the esophagus. The fact that he's got a hoarse voice takes you more towards upper esophagus. It's just an exam point to know. I don't know how likely it is to present like this in real life, but I think there's the thought that it maybe compresses the recurrent laryngeal nerve or something, and so because the cancer is high up, it kind of impacts on your voice in that way. Whereas cancer of the lower esophagus lends itself more towards reflux and that, because it's not disrupting the laryngeal nerves, it's disrupting the gastroesophageal sphincter and what have you. So we'll do one more and then we'll go through some content slides, some knowledge. By the way, I put that one as a green light because it was cancer, not because it was easy. Okay, so as a group, you're more sure about this one. So yeah, urgent referral for endoscopy. We're going to come back to the specific 2-week wait criteria for suspected upper GI cancer, but same guy again. He needs to go for OGD. So I could have been more specific, but it's endoscopy of the esophagus, stomach, and duodenum. But yeah, basically it's a camera test. So we'll review the stuff we've just been talking about. I think this diagram, I made it last year. I might have nicked it from the handbook. It kind of talks about the process of disease development in the esophagus. So acid reflux is considered benign, is a bit of heartburn. We all have that, but long term it can lead to gastroesophageal reflux disease. And then that again can lead on to Barrett's esophagus, which is what the guy in our first question had. And that is associated with a change from squamous to columnar epithelium. And then Barrett's again, especially in the presence of continued acid reflux and the factors that drive that metaplasia, is a risk factor for adenocarcinoma. So just to give context to kind of what we're going to do in the next few slides, we'll talk about GORD and then Barrett's and then cancer, because one leads to the other. So GORD, yeah, GORD it's basically a disease caused by the reflux of acid into the esophagus. So the causes and the risk factors are things that kind of will allow that to happen. So a hiatus hernia is, we've got a picture of it on the next slide, is when the gastroesophageal sphincter and the top of the stomach kind of herniate up through the diaphragm, so you lose that good sphincter control. Or if the sphincter is located in a good position but is just incompetent. Obesity and esophageal dysmotility are other things to learn. And yeah, it can, like the reflux of acid into the esophagus can cause esophagitis, which is just a bit of pain, inflammation. It can lead to ulceration if that continues. It can be complicated by a stricture, which is where due to the inflammation, the esophagus heals with scar tissue and narrows up, and that can cause dysphagia. And it can lead to Barrett's, as we've said. So the presenting things, dyspepsia and regurg, they're the key ones to be able to recognize. Belching, water brash, and odynophagia are other things that just kind of get mentioned now and again, but they're less likely to come up in a vignette. So the key symptoms are the two highlighted ones. And you can have extra esophageal symptoms, by which I mean the acid reflux can be so pronounced that it actually comes up and out of the esophagus and can affect adjacent structures in the pharynx. So it can affect like the larynx, the upper airways, and give you cough, especially in the morning, which I think that guy in the question had. He said he had an early morning cough. Can even give you infection higher up than the pharynx and give sinusitis, which is a bit of a grim thought. So what you do is, we'll go into the exact flow diagram for how you treat dyspepsia, but you first try lifestyle changes. So If the patient drinks loads of alcohol and coffee, get them to cut down, get them to lose weight and what have you. You can try over-the-counter antacids like Gaviscon, magnesium carbonate, stuff like that. And then you can go on to PPI, which is when you first count it as medical treatment. So that's like omeprazole, lansoprazole to stop the stomach making so much acid. But yeah, if you fail all that, the conservative stuff, which we'll go over again, you go for OGD, basically a camera test. And what we can see here in these two pictures, they're a bit small, but that's the change. There's a bit of ulceration, I think, that you can see. And it can present to those strips as well. And that is what the change from squamous to columnar epithelium looks like. You can have abnormal findings on OGD, which are diagnostic, but if you have normal findings, you can still have disease. So disease can occur in the presence of a normal appearing esophagus. So you can't rule out GORD, but you can rule it in. So if you still have clinical suspicion, so they still have all the signs and symptoms, but your OGD is normal, you can go for this other thing, ambulatory pH monitoring and manometry, where you kind of check how the sphincter is looking. And we've got a picture of that on the next slide. The management, yeah, we've talked about this already, antacids and alginates, PPIs, and H2 antagonists or histamine 2 receptor antagonists like ranitidine work as well. And you have surgical management. So we've got a picture of this. So this on the left, this is the monitoring that we mentioned. So you wear that for, I think, 24 hours or something, and it measures the pressure in the sphincter and the pH of the contents of the lower esophagus. And then nisso fundoplication, this is, this kind of increases the, what's the word? I don't know, sphincter function or capacity of the lower sphincter. You wrap the stomach around it and hopefully that can prevent the reflux of acid into the esophagus. So that's an option if you fail medical management. So yeah. Barrett's esophagus, I've messed up my animation orders, I'll just get it to all come up. Barrett's esophagus is a complication or kind of a downstream disease of gastric esophageal reflux. So this is characterized by that metaplasia that we've talked about, the change from squamous to columnar epithelium. And this, because this is itself a precursor to cancer, it warrants monitoring. So if someone goes for OGD and is diagnosed with this, as we can see in the yellow highlighted text, they can have repeat every 2 or 3 years just to keep an eye on it. I know they do a lot of this at UCH, so those of you who've had gastro there might have seen this. If someone goes for that and they have a biopsy taken which shows low-grade dysplasia, so like a bit of change from squamous to columnar epithelium, they can have repeat in 6 months. If there's high-grade, I haven't got a picture of that. So if it looks like it's about to turn into cancer or it has done, you can take it out then and there. So endoscopic resection is where you you suck up the tissue that's been a bit naughty and put an elastic band around it and chop it out. Radio frequency ablation, I'm not actually sure how that works. I think you put a probe down and you use radiation to just kind of kill off the tissue. Okay. So yeah, the management is endoscopic. You put the camera down and remove whatever Barrett's you see then and there. The reason you do that is because we've seen that when someone has Barrett's, it's already refractory to the medical management that you offer, you know, like the PPIs and that, or it can be. So let's say you have Barrett's for a long time, it can develop into cancer. So cancer it will usually present progressively. So a vignette might say, this person lost the ability to swallow solids, and then it's moved on to softer foods and liquids. So it won't explicitly say progressive dysphagia, but it will describe that process of kind of tolerating less and less intake. Weight loss is kind of the most classical sign, because cancer kind of has high metabolic rate that will use up energy and they'll have reduced intake. So weight loss is really likely. And they can have retrosternal chest pain. I think that relates to regurg and to mass effect of the tumour on adjacent tissues. And the alarm signs, I don't think they're as kind of up to date as they were back when we learned them. I think they've kind of been left by the wayside, but it's a good little mnemonic for learning kind of the signs and symptoms of cancer. So we'll come back to them on the next slide. But yeah, diagnosed with an OGD or a camera test, and you can see bulging in the wall of the esophagus or whatever else you see. Staging TNM. TNM for medical students is something to be aware of and to understand that higher scores are worse, but you don't need to know the TNM classification for any cancer. And that comes from, I think, Ursula McGovern, who said that, who's head of kind of oncology teaching for us a lot. So be aware of it, understand how it works, but don't try to learn it. And then management, the management kind of, again, this is very much oncological, MDT based. So you need to know the principles. So you've got chemotherapy, radiotherapy, and surgery. I wouldn't deep it more than that. Maybe know that the prognosis for esophageal cancer is usually quite horrendous. And so most people won't get surgery because you usually do surgery with curative intent. I think esophageal stenting is something that people get. You might give that to a palliative patient. So you're not going to remove the cancer, but you'll just try to delay its closure of the esophagus by putting a stent in there. It's all a bit grim. But yeah, let's talk about the two different types of cancer. We've talked about these in that first SPA. So lower esophageal is likely to be derived from Barrett's, and that's growth of glandular tissue, so adenocarcinoma. And that will present with dyspepsia, or it may present with dyspepsia, more so than upper esophageal cancer would. Upper esophagus, less kind of linked to Barrett's, more linked to alcohol, smoking, and betel nuts, which people in like Southeast Asia chew, I think. And yeah, it presents with hoarse voice and cough. And so upper and lower have some common presenting symptoms like difficulty swallowing, weight loss, and then they have these couple of things that kind of raise your suspicion more one way or the other. So I don't want to cause confusion with this. When we were learning the 2-week weight criteria 2 years ago, alarms, I think, which the red kind of listed points down there, was enough. Like you would refer according to those, but it's now been changed. So if you look in the red box, this is the stuff to rote learn. This is the stuff to look out for in a question. So anyone with dysphagia needs 2-week weight endoscopy, or anyone who's over 55 with weight loss. So we've talked about weight loss being a really typical sign of esophageal cancer, and any of the following. So upper abdominal pain, reflux, and dyspepsia. Note that esophageal and gastric cancer, as far as referral guidelines go, are grouped together. So they could present basically in the same way. It's really hard clinically to distinguish between the two. So it's kind of, when it comes to these criteria, it's useful to think of them as the same thing. So that's what I want you to rote learn, because you may have a question on this. And then the alarms, these are things that for which you would consider referral. So I didn't put a screenshot of the consider referral in because when it's a grey area, you're not going to have an SPA on it. But they're useful things to look out for because they might be like included in the list of symptoms and signs that a patient has when they present. So anemia, because like the reduced oral intake might give them a bit of malnutrition, and also cancer bleeds a lot, so they can have anemia from that. Weight loss, we talked about. Anorexia, not anorexia nervosa, which is a psychiatric condition. Anorexia is just the inability to eat or loss of appetite. Recent onset and progression, so we've talked about worsening dysphagia. Melena and hematemesis, again, are signs of GI bleeding and potentially the crappy vasculature of a cancer in the GI tract. And swallowing difficulty, aka dysphagia. So the key points, we'll just recap what we talked about because it's difficult with the esophagus. They're all very much overlapping yet discrete diseases. So reflux leads to GORD, leads to Barrett's, leads to cancer, and they all present kind of the same, and they're all managed kind of the same, but also not. So GORD is the first one. You want to go for conservative measures like lose weight, change your diet, and just sort of pray for the best. You can try your simple methods. So OTC antacids like your alginates, your bicarbs, PPIs, and H2 antagonists. If it doesn't work, it'll lead on to Barrett's, which is characterized by that histological change. That itself can lead on to cancer, specifically adenocarcinoma of the lower esophagus, which presents with the alarm signs. You can have upper esophageal cancer, which kind of is outside of this disease process and will just occur in someone who drinks and smokes a lot, not necessarily secondary to Barrett's. And then, yeah, just a few 2-week weight criteria to learn. So, and these are for esophagus and stomach, dysphagia, or a 55-year-old with weight loss and one of upper abdominal pain, reflux, and dyspepsia. So what's the difference between, I'll check the Q&A because I can see there's some stuff coming through, and then we'll move on to the stomach stuff. The difference between reflux and dyspepsia, that's a good one. Dyspepsia, I think, is indigestion or the feeling of heartburn, like acidity, and that can occur even with acid kind of contained in the stomach. So you can have that feeling in the absence of reflux. Reflux is the same thing. It's like acidic damage, but it's when it's passed into the esophagus, I think. So it's an anatomical difference, even though they kind of feel the same. Acid in the stomach, acid in the esophagus. It's hard to tell. Isaac, I think, has got the questions under control. So we'll move on because we're an hour and a half into the session, and you guys must be getting tired. So we've got another SPA. So let me run a poll for you all. This is another tough one, by the way, that I've included because UCL like it. We don't want people to come away from this session thinking that they're going to struggle on gastro in the exam. And we've only got like 7 more slides left, so we'll stop soon. So I'm going to stop the poll there. What have we got? Interesting, yeah. So most of you got it. So again, the vignette's a bit vague, and you guys need to be prepared to expect that in some questions. This woman has got a year of dyspepsia that's kind of refractory to treatment. So the most likely cause of a mass, we think, is malt lymphoma. I've given this yellow because is it common in real life? Probably not, but is it a good exam question? Yes. So malt lymphoma, I think it's mucosa-associated lymphoid tissue. I think it's like a white cell-based mass growing in the stomach, and it's more associated with H. pylori specifically than dyspepsia itself. But H. pylori causes dyspepsia and peptic ulcers. So again, it's classic gastro being confused and everything interlinking and overlapping, what have you. But most of you got it. And for those guys who didn't, dyspepsia or refractory dyspepsia, think maybe H. pylori, and if there's a cancer associated with that, it's called malt lymphoma. So we'll move on. Peptic ulcer disease. We talked about acid causing Barrett's in the esophagus, which kind of was ulceration. If it occurs in the stomach and duodenum, it's called ulcer disease. And so I won't talk about the etiology. It's kind of, there's a balance of risk factors, things that favor replenishment of the stomach wall and like neutralization of the acid, and things that drive production of acid and erosion of the stomach wall. So the risk factors link to that. So H. pylori, which we've talked about, that's an important bacterium to know. We're going to go on to the eradication regimen on the next slide. Smoking, I can't explain why smoking causes ulcer disease, but smoking's bad for most things, so an easy one to learn. NSAIDs and steroids. Now, these things, this is going back to like year 1 or year 2 pharm. They affect prostaglandin production. I think they downregulate it, and I think there's a prostaglandin that increases mucus production. So NSAIDs and steroids block mucus production. Mucus is one of the defenses of the stomach, so without that, the stomach is eroded and ulcerated. SSRIs and bisphosphonates, don't know why those cause peptic ulcers, but they're very commonly used, so they're important ones to learn. SSRIs causing ulcers, though, maybe more of a 5th year topic, so be aware of it, but if you don't want to learn it, like, that's fine. So presentation, this is similar to what we've talked about already. It's that retrosternal burning chest pain or dyspepsia or indigestion, however you want to call it, which is worse in obese people with pressure on the stomach, worse when people lie down. And the investigation of choice is OGD, so the same camera test that we've used in all the esophageal stuff. The urea breath test and stool antigen, they are tests specifically for H. pylori, which we'll keep going on about. And we'll come back to them in the next slide. And the management, same again, same stuff. So over-the-counter antacids, PPIs, and H2 antagonists. H. pylori eradication, if you have a positive test for H. pylori, which is the next thing we're going to go on to. And you can change the drug regimen. So if someone doesn't need to be on NSAIDs or doesn't need to be on steroids, what have you, you can change them. This will be a pretty brutal SBA, but you could have one where both the duodenum, like a duodenal ulcer and a gastric ulcer, are options. And there's a couple of little kind of telltale signs in a vignette that will pull you one way or the other. So duodenal is a lot commoner, I think 4 times commoner than a stomach ulcer, and is improved with food. So I don't know the mechanism off the top of my head, but a vignette will say like after meals the pain gets better, whereas if they have a stomach ulcer rather than duodenal, they'll have food and the pain will become immediately worse. Right, reflux. So this is a scary looking slide, but we'll go through it. It's kind of some of the stuff I've talked about already, and it all makes sense. So we'll take it one step at a time, and then it should be easy. So first thing to do when someone has reflux is to review the medications they're taking. So like NSAIDs, steroids, what have you. Review their lifestyle factors like alcohol consumption. And then if you fail conservative measures, you move on to medical therapy. So 1 month of PPI. And you get the patient, this is all in GP by the way, so the patient goes away, tries PPI for 4 weeks, so remember that's omeprazole, lansoprazole, and they come back and you do what's called test and treat for H. pylori. So you can test them with either a urea breath test, where you give them a drink of 13 carbon labeled urea, and I think H. pylori metabolizes that into urea, and so someone growing H, or someone like infected with H. pylori, will breathe out more of this urea than would someone who didn't have it. Or you can do a stool antigen test. I'm not sure of the exact antigen, but you take a sample of poo and test it. And in one of these two ways, you can diagnose H. pylori. So if you confirm that, you go for a 7-week kind of intense, what you call eradication regimen. So you give a PPI and you give amoxicillin and clarithromycin. And these really are like worth rote learning. I know antibiotics are a bit of a grey area. It's like, do we follow national guidelines? Do we follow local guidelines? What have you? But these ones are worth memorizing. And if someone's allergic to penicillins, you can go for Metro first line alongside Clary. So let's say you've done your 7 days of this eradication regimen. You then can't be tested immediately. You have to wait 4 to 8 weeks. So we'll say 4 weeks, and you'll test again for growth of H. pylori. It's worth knowing, because I think this is a bit of an exam topic, that the stool antigen test cannot be used after the eradication regimen's been trialled. You can use it beforehand, but after you've given the eradication therapy, you can only use the urea breath test. And so the test will go like one of 2 ways. It'll either say that you've killed off all the H. pylori and hopefully the problem's solved, or it'll say it hasn't worked, in which case you may be suspecting malt lymphoma, or you worry maybe you're barking up the wrong tree. And in either case, you go for an OGD to have a look inside the stomach, just to see whether you can kind of shine any light onto what's going on. So that is that. And gastric cancer, I'm just going to mention this briefly. There's not that much to know about it, I don't think. But yeah, H. pylori is a risk factor. We've already talked about malt lymphoma. Unsure whether it's a risk factor for other types of gastric cancer, but I wouldn't worry about that. I've not heard of it being. Smoking is an obvious one. Diabetes, pernicious anemia. Don't know why they're risk factors for gastric cancer. Hereditary diffuse gastric cancer, I guess that's like an inherited form. So presentation, dysphagia, dyspepsia, which is annoying because it's similar to esophageal cancer, but remember when it comes to 2-week weight, you treat them as the same thing anyway. Anorexia and weight loss, so these are your alarm signs again. Diagnosis, once again, OGD is the big boy that's coming up, and a biopsy. So I've highlighted this, I've just added this in today. Biopsy of gastric cancer might identify signet ring cells. That's another pathology buzzword to learn for exams. And then once you've done your exam, that knowledge poses no value in real life whatsoever. And then if you diagnose cancer, you stage it with CT or endoscopic ultrasound. And then the management, again, it's like an oncology / MDT thing. So you need to know the principles. So you've got surgery, chemotherapy, radiotherapy. You can remove nodes that have received metastasis, but that's all you need to know, I would say. And then, okay, here's a summary of dysphagia, because I want to give a bit of clarity, because we've got all these overlapping topics again. So if we go to the left, benign GI pathology, esophagitis we've talked about as being a consequence of reflux, that's inflammation of the esophagus. Stricture is again a consequence of esophagitis and reflux, that's scar tissue formed in the esophagus due to the acid like doing damage, and the stricture will narrow the esophagus and can cause dysphagia in a non-progressive manner. Like once the stricture's there, it won't worsen. that's an achalasia. I haven't really talked about that, but achalasia is like an intermittent and diffuse spasm of the esophagus. So it's going to present with dysphagia that comes and goes. It's a risk factor in itself for, well, that's diffuse esophageal spasm, sorry. Achalasia is failure of the sphincter to close. Treat with helicardiommyotomy, which is where you make an incision into the sphincter to loosen it up or to restore its function, and associated with bird's beak sign. That's another buzzword to learn on barium swallow. You can see the esophagus comes down and down and totally narrows at the bottom in the shape of bird's beak. So they're the benign causes, benign like GI causes. You've got cancer of the esophagus and stomach. Kind of think of them as the same thing. And then neurological causes. So this is maybe more important for 5th year, but stroke patients basically always at first are made nil by mouth, because stroke makes them unable to swallow, and you can have kind of reflux and resulting pneumonia because of that, which it's a kind of situation you guys maybe see in 4th year, but you'll definitely see again. So extra GI causes of dysphagia or GI dysfunction. So yeah, it's one of those things where in your mind you want to cast a wide net and be aware that lots of things can cause the problem that is at hand. Functional dyspepsia, so indigestion in the absence of an organic cause. I've included this only because, oh, that's a weird order. It's mentioned in the curriculum map. I've never seen a question on it. It's basically, you want to be aware that you can have indigestion and do all your investigations. So you can do OGD, you can do H. pylori testing, you can do this and that, and never find a cause. I think the medical want you to know that it exists, so you don't become GPs who don't believe their patients who are kind of normal on examination and investigation but claim to have these symptoms. So yeah, it's a diagnosis of exclusion because you do all your investigations and they're all normal. Is it a physical problem or a psychological? It's unclear, but you can treat kind of both potential causes. So you can give PPIs, you can give psychotherapy and low-dose amitriptyline, and you can give H. pylori eradication as well. So it's a bit of a weird one. I wouldn't worry too much about knowing the ins and outs of it. Just know that it exists, and you can have dyspepsia in the absence of kind of identifiable physical causes. And then, okay, we'll just summarize and then we'll leave it there. The rest is lower GI, which we'll do another day. So peptic ulcer disease is erosive damage of stomach acid associated with indigestion and what have you, and kind of presents as ulcers. The way to approach dyspepsia and potential ulcer disease in GP is to go for conservative measures first, and then try medical therapy, and then test and treat for H. pylori. And then if that doesn't work, bear in mind you're like a few months into trying to figure out what's going on now, you refer to gastro, probably for OGD. And that is if the dyspepsia doesn't fulfill the 2-week wait criteria. So like if it's a 55-year-old with weight loss and dyspepsia, you obviously go straight for 2-week wait. But if it's someone like a younger adult, you go down this pathway. So H. pylori, know about it 'cause it's an important cause of ulcerative disease. You need to know the eradication regimen, you need to know the testing for it, you need to know it causes malt lymphoma, and I'd say that's it. Functional dyspepsia is a weird differential, a diagnosis of exclusion, and is dyspepsia despite normal examination investigation findings. And then gastric cancer, not talk too much about it because as far as we're concerned, I think it can be bundled together with upper GI, like esophageal cancer, into the upper GI cancer package. So, you know, weight loss, anorexia, dysphagia, dyspepsia, all this, you can 2-week wait them if they fulfill the criteria with regards to age and what have you. So that is all I've got to say about that. If we've got any questions we can go through, I imagine there's not going to be too many. If you guys can be bothered to hang around, I would love to get some feedback off you. Otherwise, cheers for coming. Let me just change this. Yeah, cheers for coming and enjoy the rest of your days. But please do the feedback if you can be bothered. Because we genuinely, we try to act on all the constructive stuff as much as we can. So I'll send in some links. Yeah, cool. Can you upload cardio slides onto the G Drive? Yeah, we will do. Zero pressure to fill the feedback makes one to fill it. Yeah, I'm not trying to kind of use reverse psychology on you, but I hate it when you join a session and they're like, we're going to prolong this session by 5 minutes. We're not going to do any more until you guys fill out the feedback. That kind of pisses me off. So, and like, if people don't want to give feedback, the stuff they give isn't going to be constructive. So what's the point?